We are live.
Good evening, everyone. Welcome to the iFocus online lecture number 484 of Refractive Surgery, module number 35. Today's topic for discussion is refractive lens exchange. This will be taken up by Dr. Tushya Omprakash, sir. The moderator for today's class is Dr. Tushar Grover, sir. Sir is a cornea, cataract, and refractive surgeon. He has done his post-graduation from Arvind Eye Hospital, Madurai, and fellowship from Narayana Nethralaya, Bangalore. Currently, he is the medical director of Vision Eye Center and consultant at Sir Gangaram Hospital, New Delhi. He has delivered over 150 invited faculty talks in various national and international conferences. He is the recipient of awards in various national and international conferences, including the ASCRS, ESCRS, AIOS, and DOS. Various publications are present in journals which include JRS, IJO, and DJO. He is the reviewer for journals such as IJO and AJO. He is the section editor of the refractive surgery column at in the DOS Times. We welcome you, sir.
Thank you.
The chairperson for today's class is Dr. Bhupesh Singh. He has done his post-graduation from Regional Institute of Ophthalmology, Sitapur. He has done his fellowship from L.V. Prasad Eye Institute, Hyderabad, Narayana Nethralaya, Bangalore, and Jules Teen Eye Hospital, Hyderabad. Currently, Sir is director of Bharti Eye Hospital, New Delhi. He has performed a lot of corneal transplants, such as penetrating keratoplasty, endothelial keratoplasty, and dark surgeries with extremely good results. Sir has received achievement awards from APAO as well. He is the guest speaker at various national and international conferences. So he has trained many ophthalmologists in phacoemulsion and LASIK surgeries. Sir is also executive member of IIRS and also a library officer at DOS. Welcome, sir.
Thank you. Thank you so much.
The speaker for today's class, Dr. Tushya Omprakash, sir. He is the Chief Executive Officer at Dr. Omprakash Group of Eye Hospitals, Punjab. His interest lies in the cataract and refractive surgery, keratoconus, and dry eye disease. Talking about his achievements, he has received Best of the Best Reader Award in the ASCRS Washington, D.C. 2018. He has been awarded Gold Medal for exemplary work in ophthalmology by Bombay Ophthalmological Association. He has received Best Paper Award at various international conferences. He is also the recipient of various prizes for video presentations in many conferences around the world. His academic and professional contributions includes the instructional courses at various international conferences, including the AAO, ASCRS, and ESCRS. He has performed live demonstrations of cataract and smile at various national conferences. He has contributed to various ophthalmological textbooks and have more than 12 publications in index journals. So organizes Winter IIRSA conference in Amritsar every year. He is also the peer reviewer of the Clinical Ophthalmology Journal. Welcome, sir. Over to you, sir.
Thank you, ma'am. So, thank you for such a generous introduction. So today, I'll just start sharing my screen. Welcome, Dr. Bhupesh. We were all waiting for you. So
Thank you, Tushar. Thank you so much.
I'll just put it on the slideshow. Okay. So the topic for today is refractive lens exchange, patient selection, IOL power calculations, and surgical technique. So as we all know that the refractive lens exchange means exchanging clear natural lens with an intraocular lens. It definitely improves performance, but you know that there is always an associated pathology behind. So what's behind the growing interest nowadays? So as we see, initially there were surgical challenges in extreme eyes, but now with the new phaco dynamics and good techniques, we can overcome all of that. The earlier biometry precision challenges were there in extreme eyes, but now we have improved biometry. Then there was post-operative long-term complications. So if you do a good pre-operative workup and post-op follow-up instructions, we can also manage that. And then now there was loss of accommodation before, but now with the new intraocular lenses like EDOF trifocal, we can definitely combat that too. So what are the indications for refractive lens exchange? Definitely extreme refractive errors like myopia, so moderate to high myopia, which are unfit patients for refractive surgery, and also unfit for phakic lenses or hypermetropic patients. So I'll be first talking about the myopic patients, the patient selection, IOL calculations, and surgical technique in them. So let's start with first case, like an example, a 23-year-old myope with a refractive status in the right eye, a high myope, minus 13 diopters with 2.5 in the right, and in the left, minus 11 with 1.75 cylinder. So the pentacam shows, you can see that there's an increased superior inferior ratio of more than 1.2, plus it's a high myope case, and the thickness is also 517, and the AC depth is also low. So it is not a very good candidate for a corneal refractive procedure or a phakic lens. So what we usually do in our practice is when we get these kind of patients, we use this retinal detachment calculator, which is available online. I have kept a link also down. So what we do is we fill all these parameters. Like first is age, so it is 23. Refractive error was around 20, 12.5 to 13. Lattice G degeneration is present. So you have to keep filling these, whether posterior vitreous detachment, in this case, it was not present. Axial length more than 28, gender, and by analyzing, so this calculator has been developed based on the literally data. So what it shows is like a basic risk in this case of retinal detachment, if we don't go for the surgery, is 0.07%. But if we go for the surgery, lens extraction, it is 3.22% yearly risk of retinal regmatogenous retinal detachment. And if and the risk of retinal detachment after surgery and vitreous loss, which happens if it has happened during intraoperatively, the risk increases to 4.13% yearly. And it shows an expected round of age also when the PVD would occur. So what we do is we try to show this to all our patients so that we tell them, we fill it and we discuss it with them, and we tell them about the potential complications, and we make them aware, because it is the right of the patient to know what procedure and what risk and complications are there. So we use this as a platform, and we discuss it with the patient, and then we make the patient decide. So usually, and this is another case of 26-year-old myope male. So here the refractive status, if you see, is also on a higher side, higher myope. And if you see that the corneal topography shows thin cornea of 456 with a low ACD, and when you fill all these parameters like 26 age, 9 refractive error, presence of lattice degeneration, all these parameters, axial length of more than 28. So you can see that the detachment risk after the surgery is around 8.74% yearly. And after surgery with vitreous loss, if it has happened during the surgery, it climbs to 11.21%. So that these are the things which we discuss it to them, and we always tell these patients that what we are going to do is we're going to remove your clear lens, which is usually removed when the cataract comes, but here we are going to remove it before the cataract and replace it with a intraocular lens. So when we talk to them, we tell them about the complications like retinal detachment, CNVM, CME, endophthalmitis. So all these things have to be told in detail, especially in cases of high myopes and in patients who are young, because it is very important. If anything, any risk or complication happens, it has to be dealt together with the patient. So another challenge which comes is the IOL selection challenges. And so biometry challenges is in high myopia due to posterior staphylomas is there, because posterior staphylomas in high myopia is seen in 1 in 2 or 3 cases, and 70% of them is located in the macular region. And what happens is, because of that, you get a post-operative hyperopic error because of the longer measurements if depth of the staphloma is measured, and the error risk is greater with the ultrasonic biometry, as tilted macula can deflect the ultrasound beam. So, as we know that the incorrect, especially in these cases where you have incorrect fixations because of the posterior staphloma, it can lead to incorrect axial length measurement and wrong keratometry data. So in our practice, what we use is I don't have any financial interest in this. So we use Zeiss IOL Master 700. It is the first biometer that provides a fixation check. It helps verify if the patient has fixated correctly. So if you see here, so if you can see the foveal pit, this means it is a good fixation. If no foveal pit is visible, this means it is a poor fixation, and it can lead to refractive surprises. So, what are the benefits of this fixation check, especially in the associated posterior staphylomas? Like, you can confirm the patient fixation by checking it, as it is a swept source OCT. You can check the measured axial length and keratometry values, which is very well accurate in IOL Master 700. And you can also have an indication if there's any macular pathology present in this. So the challenge is getting a target ametropia. So you can see here with the lens power from 16 to 24, the accuracy is perfect. But when in the extreme eyes, you definitely need a array of different formulas so that you can use a average of all the important formulas. So you can see here, this study shows comparison of IL power calculation formulas for a trifocal eye in eyes with high myopia. So it has shown that the new IOL formulas like Evo, Kane, Olsen, and Barrett Universal 2, so especially in the eyes with axial length of 28 millimeter or greater, the new IOL formulas yielded the lowest median absolute error. So you have to keep all these formula in the mind. So what we do is we go to ESCRS IOL calculator, we fill in all the details, and we try to see all these formulas, and we usually take an average of all these formulas, and we decide it accordingly. So you can see here there's another case where uh, the IL power was around 4, so you can see the Barrett and Evo and Hoffer, they are almost all the same. So it shows that you can always take the guidance of all these formulas through ESCRS calculator, which is available online. So coming to the choice of IOL. So now, as we know that we have so many range of IOLs like EDOF lenses, toric, EDOF toric, and trifocal toric. But if you see in trifocals, there is an availability issue, especially with the imported trifocal and the trifocal torics, where the issue is that they do not have an inventory of less than 5 diopters. So in those cases, what you can do is you can try monofocals with planning of micro or mini monovision. So coming to the issues in overly soft lenses. So as we all know, you can see in the video also that it is not easy to crack or separate because of the viscid cohesive material. There is cheese wiring through the nucleus while chopping. And so cracking and separation all becomes little difficult. And often it is difficult to aspirate because of the cohesive mass, and it is difficult to rotate. So there is an increased chance of PCR also. So, coming to the surgical technique or pearls, especially in cases of high myopia, is that you have to remember that don't make a short tunnel, because short wounds have poor healing capacity due to low scleral rigidity. Even you should avoid making a long tunnel also, because then the manipulation of the instruments in the anterior chamber becomes little difficult. Talking about the capsular rhexis, you should do a 360-degree overlap over the optic in the periphery to minimize the rate of PCO formation. It should be wide enough to allow late retinal examinations, and low bottle height should be maintained throughout the surgery to prevent excessive deepening of the anterior chamber. So in our practice, we usually do a low IOP, physiological IOP phacoemulsification, especially in high myopes, with keeping an IOP of 20 millimeter. It also gives the patient a very good experience also, because there is no pain, and minimal pain is experienced by the patient. And another thing is that you can avoid iris lens diaphragm retropulsion syndrome also, where which is characterized by sudden backward displacement of iris, deep AC, and pupil dilatation. So if you ever face such a condition, so what you have to do is just take your second hand instrument and just separate the iris with the anterior capsular rim so that the fluid comes out and it becomes fine. And always use low IOP in high myopes. Then, of course, stable chamber settings should be used. Sudden decompression of the chamber while removing instruments out of the eye can be avoided by injection of viscoelastics from other side port prior to removal of the instrument. It avoids unwanted vitreous traction also in these patients. You can also use a femtosecond laser to make an accurately sized and centered rexus along with fragmentation or chopping of nucleus. It can thus help reduce intraocular manipulations and reduce utilization of phacoenergy. So we have published a technique, especially in a rapid technique, especially in cases of overly soft nucleus emulsification, and what are the prerequisites for rapid technique of removal of overly soft lenses are like the grade of lens should be either clear or minimal nuclear sclerosis. A good sized 5 millimeter to 5.5 millimeter CCC is essential, and you don't do hydrodelineation. We do a good hydrodissection in these cases. So when you talk about this technique, so R means the first acronym rapid you have to remember. So R stands for rotation. So do a good hydrodissection, multiple hydrodissection with the blunt chopper, placing it right on the nucleus near the rim. And then you align the phaco sideways towards the side port incision. And then P is placement of the phaco at the nuclear rim. And then comes the impaling with the vacuum in the aspiration mode. You should impale the nuclear rim and then followed by dever or emulsification of the nucleus. So it easily comes out as a whole and the nuclear emulsification becomes really easy. So this graphical animation shows that first is rotation of the nucleus, alignment, placement, impaling, and devouring emulsification of the nucleus. So this technique is very useful in such cases with no or minimal nuclear sclerosis. So this is another case where you can see that. With a good hydrodissection, uh, you can rotate it clockwise, try it anti-clockwise. Rotation is done, then alignment of the phaco is done sideways, then P placement, impaling, and emulsification of the nucleus. So you can see you don't have to use any CD also in this case. Just with the vacuum, you can complete the case with no difficulties. So, talking about postoperative posterior capsular pacification. So, this study shows that ND capsulotomy, YAG capsulotomy increases the risk of retinal detachment. So, the highest risk of RD after YAG capsulotomy, which is 12.3% in eyes with an axial length of 26 mm to 28 mm. So, we have to always think before doing a PCO in such cases. And this is another uh, study which shows that RD as a late complication of YAG laser capsulotomy. So they say that we should be cautious in doing capsulotomy in patients with retinal degeneration, retinopathies, and pre-existing retinal breaks. So you can often do peeling and aspiration of pearls, which can be an alternative under such circumstances. So if you see in this case, this video was taken by Dr. Tejas Shah. So what he's doing in this is so he's avoiding PCO, yak capsulotomy. So he's just peeling it with the normal aspiration cannula and with the just so hydrojet and peeling of the pearls, you can easily remove the posterior capsular pacification. So this is one way. And if you have to do YAG laser capsulotomy, so always remember do a low laser energy capsulotomy, and you can always remember to do a small diameter posterior capsulotomy. So what do you do when you have a plano biometry? So in such cases, it is better to leave a low powered IOL or even a plano IOL because it stabilizes the vitreous base and it reduces complications associated with posterior capsular pacifications. So you have to tell the patient that they need a regular fundus checkup, and you have to tell about all the warning signals in detail to the patient if they are willing. So you can see in this study where it showed that the patients with high myopia may be at an increased risk for late pseudophakic RD after 4 years, especially in males. So talking about the complications, as I previously mentioned that the retinal detachment chances are 1.5 to 8% in patients undergoing RLE. Myopic patients are at a higher risk because of the pre-existing lattice degeneration, retinal holes, tears, then volumetric changes in vitreous occurring intraoperatively due to change in IOP. It can cause traction, vitreous degeneration. Other risk factors are young age, greater axial length, highest refractive error, ND-YAG capsulotomy can also increase the risk of RD post-YAG capsulotomy. So coming to another indication of refractive lens exchange is the hyperopia. So it is these hyperopic patients are not good candidates for LASIK. So they are one indication for RLE, especially eyes. They have eyes with axial length less than 22 millimeter, and the short eye percentage amounts to 11% in the population. So it has smaller risk of postoperative retinal detachment. Fewer modalities are available to treat patients with high hyperopia, but there's always a surgical challenge in a very small eye. And then there is always a challenge in accuracy of biometry because even a small difference can show up with a large refractive surprise. So they can have low or normal ACD also, and there can be difficulty in predicting effective lens position also. So this study shows the accuracy of 10 IOL power calculation formulas in 100 short eyes. So they told that its study reflected a tendency of the EVO formula and the Kane formula along with older Hoffer Q formula to predict more accurately the refractive outcomes in short eyes that undergo cataract phacoemulsification. So again, we put all the things in the ESCRS IOL calculator, and you can see here that the Hoffer and Kane are quite close to each other, whereas Barrett is showing 35, and Hoffer and Kane are showing 33, 33.5, and 34. So what you can do is you can use an average of Hoffer, and Kane to get a very good outcome. Coming to the surgical pearls in high hyperopia is like, as we all know that they have low ACD and short eyes, so you need adequate dispersive viscoelastic, which prevents potential endothelial damage that can be caused by shallow interior chamber. And of course, you can use high bottle height during the surgery, which can avert the posterior positive vitreous pressure. And always remember to minimize chamber fluctuations, which can prevent any episode of expulsive choroidal hemorrhage. So in this case also, as we all know that we can use any of these IOLs. In irregular corneas, you can also use small aperture IOL. It is not available currently in India, but this also gives you a very good result. So, as we have to understand that in RLE, whenever you do, there can be residual refractive error also because of the chances of getting a refractive surprise, as we mentioned before in my slides. So, you might have to plan IOL exchange, but IOL exchange definitely is a challenging situation because it can lead to a posterior capsule rupture. It can also lead to a zonular dialysis, or as we all know that when you do yak capsulotomy also, so after that if you are planning an IOL exchange, it becomes very difficult. So one should always do anterior capsular polishing in your primary surgery so as to prevent any long-term decentration of IOLs by avoiding any fibrosis of the anterior capsule. So because as we all know that if we are going ahead with RLE and putting trifocal lenses, so you cannot afford a decentration. And then corneal refractive surgery, as we all know that we usually go in our practice we usually go for refractive lens exchange whenever we have abnormal corneal topography or if there's a pre-existing high order abrasions. And you can always use a piggyback IOL is also an option in residual refractive error or a light adjustable IOL. So talking about the light adjustable IOLs, they are FDA approved, but currently they are not available in India. But the good thing is that you can adjust up to -3 diopters of astigmatism, and you can also adjust up to +2 to -2 diopters of hyperopia and myopia in these cases. Talking about piggyback IOL, you can do that, but there are few risk and complications involved in it, like there can be interlenticular opacification. So it has to be of different material, the piggyback IOL and the primary IOL. Then you can have a postoperative elevation of IOP, pupillary optic capture after mydriasis, iris chafing, pigment dispersion syndrome. So you have to keep all these things in mind. So you need a good follow-up if you are doing a piggyback IOL. So talking about other indications of refractive lens exchange, it is performance improvement, impaired DLI, that is dysfunctional lens index, and presbyopics with normal anatomy and clear lens demanding spectacle independence. So what is dysfunctional lens index or crystalline lens aging? So it is an increased internal higher order abrasion due to a dysfunctional lens. So there is a reduced visual quality, but you have a normal visual acuity quantitatively. So DLI is a reliable quality performance indicator of the crystalline lens. Reduction in corrected distance visual acuity is strongly correlated with DLI than locks or pentacam grading. So you can see here it is it is a numerical representation of the visual quality. So in this case, it is 10. So it shows that there is no lenticular changes. Whereas when you have DLI of less more than 7, it is considered as normal. If it is between 5 to 7, it suggests moderate impairment, and less than 5 suggests severely impaired lens function. So it has three stages. Stage one is usually it is seen in 42 to 50 years of age, where there's loss of accommodation and limited scattering of light. In stage two, it starts at after 50 years, there is increase in light scatter, early lens changes may be noted or not. Glasses may or may not be suitable to correct to normal acuity. And stage three is which starts after 65 years, there are obvious lens changes, there is functional decline, and glasses are unable to correct. So let's come to a case example. So this is a 51-year-old male who is intolerant to contact lenses. So if you see in the right eye, so right eye, the refractive error is around -5 diopters. And in the left eye, it is around 3 diopters with the best corrected visual acuity of 6 by 6 parts. And if you can see in the right eye, the DLI is 10, which is perfectly fine. And in the left eye, it is around 4.62. So it shows an impaired lenticular changes are there. And when you put all the parameters in the retinal detachment calculator, you can see that the refractive error is, yeah, there is presence of lattice degeneration, absence of posterior vitreous detachment, and it shows a risk of 1.32% of retinal detachment yearly, with a risk of retinal detachment after surgery with vitreous loss is 1.97%. So, what would you do in such case? If I'm permitted, like I want to know what would Dr. Tushar and Bhupesh would do in this case, if they can join in and like if we can have discussion on this.
First of all, excellent presentation so far, Dr. Tushar. You've covered some really brilliant points, and I really like that you have this retinal detachment calculator that you're using, because it's important to make these patients aware of the potential risks of RD. So, my take is usually when somebody is under the age of 40, a high myope, I am hesitant for to do RLE unless the patient is willing to take that risk of retinal detachment that is there. And with somebody who's a 51-year-old, you can already see that there is an abnormal DLI here. So that means there are lenticular changes that have already developed. So this essentially is something I would be okay to go with, because here you're not just treating the refractive error, but also treating the issues that are in the lens. So this is almost a valid reason to do a cataract surgery as well for me. So I
Okay.
would not take it here.
And what about Dr. Bhupesh? What would you do?
Yeah, so I totally agree with Tushar. So in patients with age more than 45 or 50, if you look carefully, you will find some changes in the lenses. And if these patients demand refractive correction or they're not ready to wear contact lenses, really can be done safely, I think.
Okay. And so what would you what power would you use? Because if you can see here in the right eye, it's -5 diopters, and in the left it is -3. So what would you do? Because if you correct, then you have to do the next eye also, because there will be like an asymmetropy also.
Definitely, then you have to do only. It means there is no option of leaving one eye not operated. So better to go for both the eyes.
Okay.
And if
So
the axial length difference corresponds with the refractive error, then you're good to go.
Yeah.
okay. So if I'm like, I really respect, like, you are absolutely, both of you are saying the right thing. So what I would do in this case is, like, I would probably keep a residual refractive error in the left eye of around like -1.5 to 2 diopters, and motivate the patient to wait for the DLI changes to come in the right eye in the future, then only go for a clear lens extraction. That's like what do you have to say? Like, would that be, would you give that option too, or like would you still go ahead with taking out the clear lens in the right eye?
Personally, I
I,
would. Sorry, Dr. Bhupesh, go ahead.
Yeah, no. So I think there is not an issue in operating such cases. If the age is 51 years old and one eye has a cataract, so definitely the other eye is going to have a cataract in a year or 2 year maximum. So if in spite of leaving some residual error in one eye and then treating later, so it's better to go with the both eyes. There is no problem, I think.
And
Great.
personally, I would prefer treating the first eye, which is the left eye in this case, to plano, because that is also the one which has a lower refractive error. So that in case there is some amount of an amblyopia component, that eye is also likely to be better. So I would want to get that plano,
The
get a
best
good
corrected
visual
visual
outcome.
acuity is 6 by 6 parts in the
Yeah,
left.
but that's right now with the DLI. So post surgery, I would hopefully expect that to go to 6.6,
Yeah.
as long as there are no retinal issues. And when I get that 6.6, I would consider maybe leaving some amount of myopia in the other eye. And I would like to treat this eye to plano so that I can get the best corrected acuity in this particular eye.
Great. And what if this male patient is an active, like he has an active lifestyle, and he's driving and like doing all sort of like things in his prime time. So which lens would you prefer?
Dr. Bhupesh?
So, my choice will be mostly I prefer EDOF lenses in these cases. If it's a women or housewife, then maybe trifocal. Otherwise, I prefer EDOF in all these cases between 40 to 55 years of age group patients.
Great. And what about you, Dr. Tushar?
In my case, of course, night driving is an important question to ask. In driving to work during the day, etc., is fine for me.
He's
I would
actively
also,
driving at night.
sorry.
He's like an active driver at night.
Active driver at night, then I would consider a need off. If not an active driver at night, I my preferred lenses are trifocals. And with somebody where there is any contraindication for trifocals or somebody who is actively into night driving, like you said here, I would go for a need off.
Great, great. So I'll come to another case. So it's a 52-year-old lady. So there's an increase in light scatter. So both eyes have early lens changes, and the visual acuity is 6 by 9, and the DLI is 5.68. So I think this is an ideal case. What do you suggest? Like, right, for
Yeah.
like refractive lens exchange?
Dr. Bhupesh?
Definitely, we can go for
Yeah,
refractive assistant. There is no problem in that.
great.
If
Yeah.
So,
patient is unhappy with the vision, there is no option you have.
Yeah.
and
And hyperopes are definitely ideal cases. So anybody hyperopic with presbyopia is really the
Yeah.
absolute ideal case for a refractive lens exchange.
so this is also coming to another case of hyperopia with presbyopia, does not want to use specs, no lenticular changes, and 20/20 parts, and DLI is 10. So I think after explaining everything, all the potential risk and complications, and if the patient, this patient, particular patient, is very motivated, I think then we can definitely consider. What do you suggest? Like, would you have the same indication?
So in this situation, I think the ball is in patient's court, actually, what patients want. Because as a doctor, we cannot suggest catheter surgery or
The
RLE in
patient
these
is fully
cases.
motivated.
But if
But
patient is motivated, then we may consider EDOF or trifocal. This is not an issue. So today, I'll share an example. Today, I got a case today evening,
Hmm,
5 o'clock only. So patient is 44 years of age, around
hmm.
1.5 diopter hyperopia, and for distance 0.75 plus. The patient is saying he's not happy for distance, he's not happy for near. He don't want to use glasses. What are the options I can give it to him? So I
So,
suggest that RLE is one option that you can consider because nothing else will help in this case.
but I think if the only provided the corneal refractive procedures are he's unfit for that.
No, so it's because he's having plus zero point 0.5 spherical for distance also. So what
Okay.
refractive procedure you can do? You cannot correct presbyopia with
At
hyperopia.
1.5. Got it.
Yeah. So that is the issue. So RLE, you have to suggest RLE in such motivated patients because you don't have other options. So many times early presbyopes, they don't want to use glasses. So you have to suggest RLE in these cases.
So what do you tell patients like that you're gonna remove the clear lens and put an
So
intraocular
yeah,
lens?
yeah, I tell them that this is the option. Although it has some complications or some risk, if you're ready for that, you may get some number also eventually because the lens displacement or capsular contraction that we may treat with the laser thing later on. But right now, this is the option. If you
And
want,
you'll
we
be,
can do it.
Dr. Bhupesh, you'll be surprised like when such like you mentioned the case today, no, when they come to us, no, when I tell them that usually we remove the lens only when there's cataract, and when I tell them we are doing it in a natural lens, so
Yeah.
90% of the patient they just run away.
Yeah, so it's a general understanding or tendency of the patient to think that if it is normally working lens, why you to remove? But
Yeah.
in if you talk about the population which we practice, patients clearly understand the physics behind the vision, and if you
Right.
explain that, then they will ready for the surgery.
Yeah. No, I'm just saying like
Yeah,
this kind
true,
of
true,
like
true.
I think if it's important for us to tell them the actual benefits and the risks associated, and I think if these patients run away, that's fine. I think that
Yeah,
we are, on our part, we should be telling them all the risks that are associated, which is why for me, for a hyperope, the threshold for doing an RLE is much lower because there aren't as many risks associated. Whereas for a high myope, you do have that significantly higher risk of developing an RD, especially in a young patient. So I think it's important for us to discuss that with the patient, and not doing a surgery is a perfectly good option as well, which we should be open to, I think.
so coming to other indications are angle closure glaucoma, severe anisometropia with impending amblyopia and pediatric age group where corneal procedures are contraindicated. So, RLE in angle closure glaucoma is a therapeutic option before trabecular damage occurs, where topical treatment and peripheral iridectomy are ineffective. So, this is a case where 52-year-old lady, IOP, barely controlled, progressive field defects, clear lens. So, in such case, it is a good option to go for refractive lens exchange. Talking about the contraindications for refractive lens exchange are corneal diseases, age-related macular degeneration, diabetic retinopathy, risk factors for retinal detachment like advanced peripheral lattice degeneration, lacquer cracks, ocular inflammatory diseases, and patients with unrealistic expectations of the outcome who are unwilling to attend regular follow-up or to accept the inherent risk of the surgery. So, talking about the prerequisites for success is proper patient selection, optical swept source biometry, and use of multiple formulas, safe intraoperative technique, consistently good gives you a good, consistently refractive outcomes, and a very good pre and post operative counseling. So, always under promise and over deliver since patients have high expectations. The, and tell them in detail about post operative long term complications and the loss of accommodation. So coming to the take home points, all are in our practice we avoid it below 50 years of age. We are very conservative, especially in high myopes. So we can think of doing RLE in a DLI of less than 7 in moderate to high myopias, where the PVD is actually already present, and hyperopic with presbyopic correction and indication, like Dr. Tushar said, if patient is motivated, and angle closure glaucoma. So thank you so much.
So once again, excellent presentation, Dr. Tushya. You covered really important points very comprehensively. I really like the fact that you're using the calculator to educate the patients as well. I also really like that you're using the ESCRS IOL calculator so that you can, compare all the formula, because these extreme eyes, you do tend to get uh, poor calculations, or inaccurate calculations at some points with any of the formula. So it's always good to have multiple formulae as a reference. And having said that, of course, the newer formulae, including the Barrett Universal 2, the Kane formula, the Lada super formula, all of them do tend to perform better than some of the traditional formulae. Dr. Bhupesh, your points.
Yeah, definitely. So excellent presentation, Tushya. I have some points to discuss that we should discuss. First thing is the IL part selection. So, example, in cases of myopes, if you're operating myopes with RLE, we should target emetropia or we should target myopia in such cases.
So it depends if you're which lens are you gonna use.
If
If
monofocal,
you're using monofocal, then what I we do is micro mini monovision is the right choice. So I think that would should be. What is your take, Tushar? Like, do you have?
Yeah. So even me with monofocal or with EDOF, I do usually plan micro monovision. In terms of choosing which IOL power to be chosen for each eye, when it's monofocal or EDOF, I choose the first minus. But if you're implanting a trifocal, there is evidence that suggests that you should choose whatever is closest to zero, not the first minus. So that's what I go with.
yeah. And the second thing is regarding the phaco technique or the phacoemulsification. So what I find in clear lens extraction, if you could do a good hydrodelineation, you don't need phaco probe to you. You can do the IE and remove the lens easily. In most of these young patients, at least below 35 years of age or 40 years of age, you can easily do IA and get rid of this, because getting the surge in these cases, high myopes are very high. So with phaco probe with the clear lens, it's sometimes you get a PC rent also, because suddenly AC becomes deep and it becomes shallow. So chances of rent is there. So better to go with IA and finish the case.
True. I agree. Very true.
Very good point. Like,
With
Yeah,
many of the
and
young patients, it's just the aspiration that does the
yeah.
job. It's
So
sometimes
delineation is a good thing, I think.
correct. And it's sometimes the 40 to 50-year-old where you do have some endonucleus. It is extremely helpful to do the delineation and get rid of that
Mhm.
endonucleus, and then everything else becomes very easy.
Yeah. Second thing, what I find in such cases in post-operative period, most of these young patients develop capsular contraction syndrome eventually. If you operate 20-year-old patient or 30-year-old patient, they develop fibrosis, phimosis, and all these things are there. So whether
you're
we
right.
should keep rexis size slightly bigger in these cases, or we should go for 5.25 or 5.5 only.
So I think we should keep a little around more than five. It should definitely not small. And secondly, as I told you, as I mentioned in my presentation, interior capsular polishing, if we can do, that also plays a very important role, because these are the lens epithelial cells which are going to contract and cause phimosis and fibrosis. So I think interior capsule polishing, doing especially in these premium IOL cases and RLE cases, is very important.
Yeah, I think
Absolutely.
5.25, 5.5 is the ideal size, because if you're too big, you also increase the risk of PCO. Whereas if you're too small, you increase the risk of phimosis. And like Tushya pointed out, doing a YAG in these patients is also has its risks, because it increases the chances of RD subsequently.
And one more point is the use of CTR in these cases, because if these high myope patients, if you're doing RLE, whether we should use CTR or there any cutoff with the axial length. So what is your take, Tushar or Tushya?
So,
So basically, I
Tushya,
have you can go ahead, Dr. Tushar, you were
no,
saying.
so I personally don't think, I mean, at least it's a personal thing. I don't think there is enough evidence to really point out that CTRs in all cases are of benefit. I don't routinely use CTRs in these cases unless, of course, there is an indication.
So in our practice, we have hardly done any RLEs as of like our indications are very restricted. So and we have never put CTR. So I think like what Tushar is saying is absolutely.
What about the high myopes if the axial is more than 30 or something like that, and you're operating cataract, then also no CTR.
I'm not using CTR, but what about you, Dr. Bhupesh?
So I routinely use CTR in very high myop patient if axial length is more than 29 or 30. So I prefer to use using CTR because the bag is very big, and if you put a lens, it keep rotating there. So once you put CTR, the bag becomes tight, and so I feel that lens is more stable in very high myop, where the eye power is -1 or 0, something like that. So in such cases, I find CTR can be used.
Great.
And uh,
If I may ask one question,
yeah.
is somebody 45-year-old who is suitable for a phakic IOL as well? Would you consider a presbyopic phakic IOL? Would you consider RLE? 45, 50-year-old, would you do a phakic IOL in them?
Yeah, so if the lens is totally normal, we can do phakic IOL. There's no problem because you can give at least 10 years without surgery. So phakic IOL is an option, good option
Tushya,
in
what's
such
your take?
cases.
45, 50-year-old with clear lens, eligible for phakic IOL, myope, what would you do?
So I haven't done presbyopic phakic IOL. So we restrict ourselves only to corneal based procedures if it is possible. And we don't like in our practice we have not been like very aggressive with clear lens extraction in those cases.
I agree. I think I work on similar lines as well, especially with high myopes. I am a little on the back foot with RLEs, primarily because of the risk of RD subsequently. So I tell them all of this, and I hope that it discourages the patient enough to not get it done. Because I think we have to understand
Exactly.
also as surgeons that not doing a surgery in some patients where there is a risk post-operatively is a good option. It's not a bad option. We don't
That
have to operate on every.
you said it right. That's what we do. We try each and every possible way to discourage them, not outrightly, but in such a way that they don't go with those surgeries.
Okay. And
Great.
presbyopic lasers, say Presbyon, Presby Max, do any of you prefer that in
I
45
don't
year old?
have Press Beyond. What about, I think Dr. Bhupesh is doing Press Beyond. He has,
No, no, we are not doing. The results are not very encouraging actually.
yeah.
We had the software in that machine, in the clear machine, but the results are not very great. So we're not doing.
Think it becomes very difficult to explain to the patient because anyways it'll come back and then you have to do retreatments and everything.
Yeah.
So
We did a trial of in NIDAC examiner also. The name was Presbyopa, but the result was really not good. So we stopped doing that also.
okay.
And another challenge comes when, say, a 45, 50, 55-year-old with clear lens, plano refractive error, wants to get surgery done just for the address for correction of presbyopia. Again, there, I think most of us are not very enthusiastic about operating. What is your take, Dr. Bhupesh, Tushya?
So that is the most difficult scenario because you're not sure whether you're going to give 6 post-operative or not. So that is another concern in such patients. So better to avoid such cases only.
Tushya,
So
what's your
same thing we try to like discourage them.
correct. So I think all of us are slightly science based. We understand the limitations that biometry or any of these things has in all eyes. Even in the most normal eyes, you cannot get uncorrected 6/6 in all cases, despite having the best biometers. And of course, these are limitations that still do exist. In extreme eyes, of course, there is that possibility of refractive surprises to a certain extent. Any questions that we have on YouTube or any questions that the audience wants to ask?
So there is one question that I want to ask. We were talking about, sir, refractive surprises after the lens exchange in cases of myopes and hyperops. So how can we manage them if we get a surprise?
Tushi, would you like to go first?
So yeah, so as I told you, like there are a couple of ways, like a piggyback IOL. Then there are a couple of IOLs which are not available in India, like light adjusted IOL. So you can correct with them also. And then you can always, I think IOL exchange is another way. So, but there are challenges associated with that. Like I told you, like you can have PCRs on or dialysis and all of that. So you have to keep all these things. So it is, of course, challenging. So you have to keep that thing in mind, and you have to counsel these patients pre-operatively that all these challenges, if they come, so they have to deal together. They can't blame on the surgeon. So, and as Dr. Tushar was saying, in extreme eyes, there is a definitive chance of getting a surprise, especially in hyperopes also. So, what do you have to say, Dr. Bhupesh and Tushar? Like anything you
So
want?
my preferred method is laser-based procedures. In all refractive surprises, I prefer laser-based procedures. Just do a surface ablation and finish the residual.
But what if even if they are unfit for the cornea?
No, if they're not, see, RLE we do usually for very high myo patients, and residual will be 1 diopter, 1.5 diopter, not more than that usually. So you can correct 1.1.5 easily with the refractive surface ablation.
Okay,
Yeah,
very
I
good.
would agree with that. So as long as it's something that we can laser and the cornea is healthy, definitely doing a laser-based procedures, in most common cases, if it's a small refractive error, doing a surface ablation would be the first way to go. If it's a much higher refractive error, then of course you can consider options like piggyback IOL, which I would consider before IOL explantation.
Yes, sir. We
Any?
don't have many more questions, sir.
Okay, all right. And Dr. Bhupesh, any other comments?
Yeah, that's a really wonderful session, and thank you, Tushar, for a wonderful talk.
Thank you so
And
much.
thank you, Tushar.
And thank you,
So,
Tushar, also for this.
yeah.
Thank
So
you,
I
Dr.
think we should conclude the session, I think.
Yeah, excellent talk, Tushar. Really, you really covered all the points very well.
Thank you so much. Thank you.
Thank you. Thank you so much.
Praveen, for the coordination and everything.
Thank you so much, sir.
Thank you. Thank you so much.
Thank you, sir.
Thank
Good
you.
night.